Our next section is going to be dealing with head trauma. If a patient presents to you with head trauma and it resulted in altered mental status or loss of consciousness, you must get a head CT first. But the question is, with or without contrast? A head CT without contrast is the best initial test to detect blood. Contrast actually obscures seeing blood on the head CT. It's better for mass lesions, such as with cancer or abscesses. During your USMLE, if you read loss of consciousness, get a head CT. A concussion will present to you with no focal neurologic abnormalities, and when you obtain a CT scan, it's going to be read as normal. A contusion will present with some focal findings. It's rare, but it could happen. The actual CT will show an ecchymosis, which is basically blood mixed in with the brain parenchyma. Now here's a brain CT of somebody who has a contusion. Lateral to the midline, you can actually see blood mixed in with the brain parenchyma, but it doesn't collect in a way that allows drainage. There are two kinds of hematomas you must know: subdural and epidural hematoma. They're usually associated with severe head trauma, such as those involved in motor vehicle accidents or falling from the top of a building. Now the thing is, it's impossible to distinguish without getting a head CT. A patient won't come to you and say, "Oh, I have an epidural." Epidural hematomas are also more frequently associated with a skull fracture. Here's a classic example of an epidural hematoma with the pathognomonic lenticular hemorrhage. They're usually from a high-pressure artery that's broken. One of the ones you must know for the exam is the middle meningeal artery. Now here's an example of a subdural hematoma. Notice on the left the classic crescent-shaped concave surface of blood. Note also how it crosses the suture lines and involves a greater proportion of the cerebral hemispheres. The lucid interval is a second loss of consciousness that occurs several minutes to several hours after the initial loss of consciousness in a patient with head trauma. The patient will wake up after the initial loss of consciousness, but then subsequently loses consciousness a second time due to the accumulation of blood. Time between this first and second episode is known as the lucid interval. Remember, both epidural and subdural hematomas are associated with the lucid interval. There is no specific therapy for concussion. You must, however, instruct the patient to wait a minimum 24 hours before returning to any sports. A contusion also has no specific treatment. However, there is a small group that needs surgical debridement. Patients with concussions are safe to go home. You don't necessarily need to hospitalize them, but you must instruct someone to be with them and observe them for altered mental status. If that occurs, they are to be brought back in. The treatment of a subdural and epidural hematoma are based on two factors. The first is the actual size of the bleed, and second is the patient displaying any signs of compression. Small bleeds are left alone. Large ones, however, are actively managed with intubation and hyperventilation to reduce intracranial pressure, mannitol to take care of the cerebral edema, and lastly, surgical drainage in case the bleed is so big there's mass effect. Now, what are the three hallmark components to define a large intracranial hemorrhage? Well, first, if there's any compression of the ventricles or sulci, if there's herniation with abnormal breathing and a unilateral dilation of the pupil, and lastly, if there's worsening mental status or some focal finding on the neurologic exam. Now, to summarize severe head trauma, remember, concussions have no focal findings, whereas a contusion can rarely give you focal neurologic findings. The subdural and epidural can give you some form of focal neurologic findings. When it comes to the lucid interval, a concussion never has one. A contusion also does not have a lucid interval. The subdural and epidural can have a lucid interval. A CT scan with a concussion will be normal, whereas for a contusion, they will show an ecchymosis. On a subdural bleed, you're looking for a crescent-shaped pattern because it's a venous-type bleed. On an epidural, it'll be biconvex or lens-shaped hematoma. Remember, that's an arterial bleed. The treatment for a concussion is nothing specific. Remember, just observe them at home, and if they have any form of altered mental status, bring them back to the hospital. For a contusion, there again is no specific treatment, but in contrast to the concussion, you observe them as an inpatient. A subdural, remember, you drain the large ones, and for an epidural, you also drain the large ones. A 25-year-old man sustains head trauma in a motor vehicle accident. A large epidural hematoma is found. Immediately after intubation and mannitol, surgical evacuation is performed. Which of the following will benefit the patient the most at this time? Is it A, repeated doses of mannitol? Is it B, continued hyperventilation? Is it C, a proton pump inhibitor? Is it D, nimodipine? Or lastly, E, to give dexamethasone? The correct answer here is proton pump inhibitor, C. A PPI is always given to prevent stress ulcers. The only clear indication for stress ulcer prophylaxis are burns, endotracheal intubation, and a coagulopathy. The incorrect answers are wrong for the following reasons. We do not give repeated doses of mannitol because it does not reduce mortality. We don't continue hyperventilation because it has a very short-term efficacy and is probably ineffective after the first 24 hours. We don't give nimodipine because that's for subarachnoid hemorrhage, and dexamethasone, a very potent glucocorticoid, is ineffective for intracranial hemorrhage. The USMLE loves to give distractors. Remember, steroids don't benefit intracranial bleeding. They only decrease edema around mass lesions.